Okay, so pain management. So there's a recap on our letter A of the ABCDF bundle, right? So we're assessing and treating pain, at least how often? Every 4 hours. And how do you assess it? Numeric scale is the best. If they can wake up and tell you a number, they can show you numbers, that's perfect. That's actually the best scale you can ever use for pain. But if they can't wake up and give you a number, then that's when we start using CPOT, right? Behavioral pain scale, or BPS, is an alternative, but we use CPOT here, right? And our medications that we give for pain are based on the CPOT scale, right? So our drips, which we'll talk about in the upcoming slides, and pushes are given for a CPOT greater than 3 usually. Right, so as we mentioned, the stepwise approach, right? Step one is just give straight up Tylenol, see if that helps, right? And we have IV Tylenol we can get. What's the name for IV Tylenol? They should just call it IV Tylenol or IV acetaminophen, but it's not. It's called Ofirmev, right? So Ofirmev, that's actually the brand name, but there it is called IV acetaminophen. I think it's reached the 10-year mark where we don't have to call it Ofirmev anymore. But either way, it's expensive, right? Pharmacy doesn't like it, but for a patient that is in the ICU, they probably require it for at least 24 hours, right? So someone is getting agitated, someone is getting febrile, someone has pain, we can give IV Tylenol just around the clock, right? If they can't take PO, we got IV, right? Oh, they're post-op bowel surgery, can't give it. It's like, yeah, I'll give IV Tylenol. That's perfectly fine. Right, so we give Tylenol first, and then we switch up to a PRN push, right? So PRN Dilaudid, right? A PRN fentanyl push if they have a tube in place, right? That's something that we can then stepwise add it. We don't want to go straight to an opiate infusion, right? I start a tube of fentanyl, all my intubations. It's like, why, right? Let's start some IV Tylenol, let's start some pushes. If they really need it, we tried the steps, then we could go ahead and go to a continuous infusion. Okay, as we know, fentanyl is our strongest IV analgesic we give in the ICU. There is something stronger called remifentanil. I think I have it on the fentanyl page. That is a little stronger than IV than our fentanyl we use in the ICU, but it's usually only given in the OR for short cases. Okay, and it should be reserved for short vent times. You shouldn't have it for prolonged periods of time. Otherwise, it can definitely cause constipation. We know that, right? Our morphine binds everywhere, but it's going to bind specific opiate receptors. And we do have opiate receptors on our gut, right? These little mu receptors on our gut, and that's going to start causing decreased peristalsis and constipation to an ileus formation, right? So we should be reserving fentanyl for those that are, have just like a short ventilator time, or they have like severe chronic pain, right? Like an 87-year-old grandma, you don't want us to go and say, oh, I'm giving you IV fentanyl. It's like, maybe that might be too much for grandma, unless grandma also has rheumatoid arthritis and chronic back pain and all the other things. And yes, then giving these higher, starting a little higher on a stepwise ladder might be beneficial. Okay, so Dilaudid and morphine drips are alternatives. You don't have to start at fentanyl, right? Fentanyl is how much stronger than morphine? A lot, right? It's about 100 times stronger than morphine, right? So if you give, give 10 of morphine, that's a 0.1 of fentanyl. It's 100 times stronger. So we want to be cautious of that, because sometimes we're giving a fentanyl infusion of like 200 mics or even 400 mics, right, per hour that we're giving, right? That's like you're going into the patient's room with a morphine like every 10 minutes, every 15 minutes of 10 milligrams of morphine, which is a lot of morphine. Okay, or Dilaudid every 10 to 20 minutes. You're giving like 2 to 2.5 of Dilaudid every 10 to 20 minutes. That's a lot of Dilaudid, right? So we got to be careful when we think about giving fentanyl that it's a very high dose of opiates, and it's going to have a lot more constipation, for instance. They have a lot more other side effects. Yes, it's going to control pain, great, but it can also cause some euphoria, right? Hypoxia if they're not tubed. That's why we want to make sure they have a ventilator in place before we give these high doses of infusions of opiates. Okay, bradycardia can occur as it starts suppressing central nervous system pathways, right? And then morphine specifically causes a lot of allergic reactions. It causes a lot of histamine release, and therefore you get itchy, right? You get urticaria, you get bronchospasm, nausea, vomiting, has this allergic reaction with morphine. So you usually don't give morphine infusions to patients that are not comfort care. So if they are in the ICU and they need pain management, IV pain management, we got IV Dilaudid or IV fentanyl. Usually IV morphine is not going to be given because it might cause further hypotension, might cause an unknown rash, might cause bronchospasm, and someone's on a ventilator. That's not great, right? So yeah, it causes nausea, vomiting as well, but the reason for IV morphine is usually for someone who's comfort care. In those cases, we're okay with those side effects. The primary reason for morphine, it takes away that breathlessness sensation for a patient that's end of life, so that's actually a benefit to us. All right, so how do opiates work? They're attached to opiate receptors, many different places throughout the brain, of course, also in the GI tract, but it's stopping these excitatory neurotransmitters from being released, right? Or it's stopping the calcium channels from being activated. As we'll learn, calcium channels are excitatory, and when they get activated, they start turning on the lights in every single cell, and including the periphery, but also in the brain. And that could cause seizure activity. And it makes sense why we give opiates to kind of suppress that. Are opiates anti-seizure? No, but inhibitory neurons of some fashion can inhibit seizure activity. Which inhibitory neurons were those? Those were our GABA neurons, right? All right, as we mentioned, the strengths, right? Fentanyl is 100 times stronger than morphine. It's 7 times stronger, it's 12.5, I think 15 times stronger than Dilaudid. And Dilaudid is 7 times stronger than morphine, right? So just the stepwise nature of the IV pushes, right? So morphine you can give. Sometimes we'll avoid in the ICU for that reason of, it's like the fifth time I tripped on that. I'm going to move it at the break. So yeah, so it's going to cause a widespread allergic reaction, right? So the other piece is that morphine, one of its metabolites, is toxic to the kidneys. So if someone has kidney failure, we're not giving morphine, right? So besides the anaphylaxis and whatnot, it's also the renal failure. These metabolites can build up and cause more renal failure. Okay, so fentanyl drip. So it is very commonly used because it's a short half-life. Like I mentioned, remifentanil is another agent that is used in the OR. It might make its way out to the ICU eventually, but it's also pretty pricey, right? But fentanyl drip is great because it has great analgesia. It's 100 times stronger than morphine, so it definitely can provide some analgesia. And we know that analgesia is a critical element of our triad of pain, agitation, delirium. So if we give fentanyl, it can hopefully abate those other problems, right? The other benefit of it is that it also causes sedation. So not only does it provide analgesia, it also provides a little bit of sedation, so it's an analgesic sedative, which is nice, right? So the problem is that we usually use fentanyl for 2 days, 3 days, 5 days, 7 days of continuous infusions, and it can actually cause hyperalgesia, right? So that is too much pain, right? It downregulates the pain receptors to the point where they start getting so much pain from any kind of movement in bed or any kind of procedure that's being done. So that is a problem because now you have your fentanyl at 2 mics, 3 mics, 4 mics per kilo per minute, and we are not getting any kind of pain management. It's like, well, I'll just keep going with fentanyl, I guess. Well, it itself might be causing the pain, right? Besides the effect that it has tachyphylaxis, as we mentioned, with increasing doses, 2 mics day 1, 2 mics day 2, 2 mics day 3, just that rapid timeline causes a reduction in fentanyl's activity, right? It's not, you could think of it like tolerance, but tolerance again happens over weeks. Whereas fentanyl, just each subsequent dose 1, dose 2, dose 3, causes a decreased effect each time in the body. The body adapts to the fentanyl every time. Which other sedative had that property? That was our
Propofol?
Propofol is a pretty continuous. It doesn't have, they don't really adapt to propofol. Precedex or dexmedetomidine. All right. So fentanyl you can bolus, and usually, as with the previous page with the ladder, right? Usually we'll do PRN opiates first, right? So instead of starting a fentanyl infusion, right? Sometimes we have nice providers. They'll say, "I'm gonna give fentanyl just in case you need it," and they turn around, the fentanyl already started. Oh, I thought you said in case you needed it, right? But it's like we should be doing fentanyl pushes first, right? You have 50 mics of fentanyl after Q1 hour, and it's not working, then we can consider getting a drip infused. Okay. All right, so after that, what else? So again, greater than 2 is a lot, right? So if we are giving more than 2 mics per kilo per hour, I think I said per minute earlier, but mics per kilo per hour, that is a lot of fentanyl you're infusing, right? If you have a 100 kilo patient, 2 mics per kilo per hour is 200 mics, right? And remember that 100 mics, or 100 mics is 10 milligrams of morphine. That's 20 milligrams of morphine you're giving them every hour, right? And morphine comes in vials like 4s, right? That means you're going to the Pyxis and grabbing about 3 vials of morphine twice in that hour, right? That's a lot of morphine you're giving a patient, right? So we want to be careful when we're giving more than 2 mics per kilo per hour of fentanyl. All right, so prolonged fentanyl infusions. Besides causing hyperalgesia, right, it can accumulate in fat tissue like our benzos do, right? And that can, especially that's like after 2 or more days, and that can lead to prolonged sedation. Right? They're not waking up from the vent. I can't figure out why. It's because we should probably, it might be the fentanyl infusion they had going on, right? And if they're bigger in size, a higher BMI, it can stay around for longer, right? And it increases your vent days, ICU days, and hospital days because of that. And they develop tachyphylaxis, as we mentioned. And also, they've been on fentanyl at 5 mics for 7 to 10 days. They're really sick and they got better. And now you can't get them off fentanyl because it's, they get tachyphylaxis, but also they get withdrawal symptoms, right? So withdrawal symptoms can develop as well with prolonged use. Right, so just like someone on the street that comes in, they don't have their fix, right? They're going to start getting sweaty, diaphoretic. They're going to get tachypnic, tachycardic. It's like, oh, they keep failing the SCT trials. It's because they're probably on a long dose of fentanyl for a while. Okay, so what else? So GI side effects. As we mentioned, it can start causing really profound constipation. So how do you fix that? We can start a bowel regimen, which we'll talk more about in GI, but we could give a special medication. It costs about $1,000 per dose. Right, it's called methyl naltrexone or Relistor. Okay, so Relistor is a medication that's used for specifically for opiate-induced constipation. All right, that's its one and only thing is opiate-induced constipation. Is it going to work for someone that has an ileus because they have a C. diff colitis? No, it only works. It just pushes aside the little mu receptors on the GI tract. It pushes all the opiates that might be bound there. It says move. It gets aside, and now you have normal function, hopefully. Okay. So alternatives to a fentanyl infusion. So we can use a morphine infusion, but again, this is really for comfort care because it has the side effects of what? Not so much anaphylaxis, but it has allergic side effects. It causes histamine to be released, and that can then cause a, pruritus and cause, inflammation, etc., but also cause hypotension, which is not great to someone who's like in a shock state in the ICU. As we mentioned, it has toxic metabolites that can build up in AKIs and kidney insufficiency. All right, but a Dilaudid infusion is perfectly fair game, right? So you can use a Dilaudid infusion instead of a fentanyl infusion. Okay, and again, remember it's 100 times more powerful than morphine. Use PRN pushes before we go to an actual infusion to the patient, right? Because 50 mics might be all they need every 2 hours, right? Whereas if you're doing 2 mics per kilo and they weigh 100 kilos, that's 200 mics you give them every hour, right? So instead of doing 400 mics in 2 hours, just 50 mics, that's better. Yes?
Does the Dilaudid infusion have any side effects?
No, Dilaudid infusion does not have the same side effects like morphine does. Does it have the same side effects as constipation? Yes, it does. Okay, so what else on fentanyl? So it also causes this skeletal muscle rigidity with high doses, which is not great for weaning, right? It's like you breathe and they can't because their muscles are literally like frozen, right? So that's not great as well to get patients weaned out the ventilator. So we want to have lower doses of fentanyl if possible. And of course, titrating to a CPOT of less than 3, right? So the CPOT is 0 at 8 o'clock, CPOT 0 at noon or midnight, and CPOT is 0 at 4. Why are you still on fentanyl 2 mics or fentanyl at 1 mic, right? You should have gone down a little bit each time, at least. All right, so ketamine. So ketamine is a newer agent, not so new because it came out in the 60s, right? They started doing tests on, on soldiers on ketamine from the post-Vietnam Wars, post-Korean Wars. They had, they did LSD experiments, and we kind of got ketamine out of that, right? So ketamine is not a Schedule 1 drug, which is like heroin, cocaine, and such, but it is a Schedule 2 drug that requires a little bit of, monitoring. Right, and it's getting a lot more use in the psychiatric world, right? It can actually cure someone's depression, which is cool, right? It causes dissociation, right? So it causes you to literally be disassociated from your body, where you have those what's called end of life events where you are seeing yourself floating and you see your body there and such. This causes that by itself. You give a dose of it, they can literally dissociate from the body and they can see themselves and how depressed they are. It's like, whoa, shoot, I should change, and they just change, right? So it's actually it's a great therapy for depression nowadays, right? So, but the other piece is this is great for a psychiatric patient or a schizophrenic patient where they see themselves in the room all of a sudden, they can't wake up and they can't do things. Probably not great, right? So it can induce psychoses, which is not great, right? So ketamine has what's called a bimodal pain dosing. So it's great at low doses and it's great at high doses. But in the middle, that's where it starts causing psychosis and causing a lot of problems. So we got to be alert to that because sometimes you're titrating ketamine, you start at a nifty 0.12, right? And you then go, you're 0.1, you're in the analgesia range, you're controlling pain management, and you keep titrating up into the psychosis zone. And you're not going to get to the actual sedative zone until you get past the psychosis zone. So really, it needs to be very, very specific, and unfortunately, it's not. So the order that comes default from corporate is not beneficial. It could cause problems, right? So oftentimes people start ketamine, it's like, oh, the heart rate's super high. It's because they're having that worst trip of their life right now. That's why the heart rate's high, right? So what we need to get to higher doses so we can stop that psychosis and we can actually provide sedation, right? And even then, the max dose is 0.9, right? And you don't actually get sedative doses until 1. So it's like you're never going to actually reach sedative doses. That's why we say, oh, ketamine fails, ketamine fails. You can see a lot of poor attitudes on ketamine, but it doesn't, you have to have the order changed, unfortunately. So that's why we illustrate this, is that it's insufficient, and the MD needs to adjust that dosage, or the provider needs to change that, not to 0.9 max, but like 2 mics max. Right? So that way you can say, hey, we give this for sedation. Well, I'm going to start it at a little, or maybe I'll start at a low rate, and then I'll then titrate it up to the high rate that it should be at. Not sequentially, but you're going to see if they're tolerating it, and then you'll then start it at the higher rate. Okay, and of course we have to have our orders match that, right? And because otherwise it'll say, what are they doing? Why are they jumping from point A to point B? We have to have orders to explain it. So that's why we want to make sure our orders change for that reason. All right, as we mentioned, ketamine is a NMDA antagonist. NMDA is excitatory. It causes a lot of problems, a lot of excitation, a lot of pain. So this is a what? This is a analgesic sedative, right? So it causes sedation, and it causes analgesia, right? And again, I mentioned it's bimodal. The lower doses cause analgesia, perfect, right? But if I want sedation, I got to use those high doses, and yes, it'll cause some pain control as well. Okay, so it causes profound analgesia, right? It also stimulates the SNS a little bit, so that's going to cause bronchodilation. So it's great with asthmatics. It's great for patients that have bronchoconstriction because it's going to be beneficial to help open up those airways, right? So someone is on the ventilator or COPD exacerbation, ketamine is perfect because it's going to A, provide pain, but also B, it's going to bronchodilate, right? It's also great for patients that are in shock states because it's also going to provide a little bit of vasoconstriction, right? So not significant amounts, not a pressor, but it's going to stimulate the SNS a little bit to cause a little bit of vasoconstriction. So it's going to, counteract the shock process, the hypotension that might develop, right? So what else? So yes, it also increases acetylcholine. All right, acetylcholine is found, yes, it's found in the heart for the parasympathetic nervous system, but it's also found in every gland ever. So it's going to make them really, really juicy, very diaphoretic, and a lot of more secretions. So people will say, well, if it's going to cause more secretions and they're going to aspirate versus bronchodilate, which one's better? Well, it's usually the bronchodilation is better, but we have to be alert that they need to be able to manage the secretions. This is why there's a debate about whether to use it after extubation or not, because they might develop more secretions, it might need to be reintubated. But it is a great agent otherwise for, yes, respiratory, also for patients that have little shock processes. And it's going to also be, what else? It was once thought that it causes increase in ICP and increase in intraocular pressure, but that's completely been busted. There's no evidence that actually happens. What is plausible, probably should not use it with schizophrenia. They're going to get a very, very more psychotic because of that, right? So yes, it causes a lot of acetylcholine release, and you can get vomiting once they come off ketamine. So that's something to be alert to, especially if you're going to give this in like the outpatient setting or the ER setting, where you have those holds in the back corner of the ED, and they get like a ketamine infusion going. Then they got to be able to monitor that after they come off the ketamine. Okay, so what else on ketamine? So ketamine, again, is a great agent, and sometimes it's used in combination, like ketofol or ketodex, right? So they use ketamine with propofol, so it counteracts the hypotension propofol, and it has synergistic activities, just like vasopressin and Levophed is synergistic. Ketamine is synergistic with the other sedatives as well, provides more sedative effect and more analgesia, right? Propofol causes no analgesia, so ketofol or ketamine is going to be added to that situation. It's going to definitely improve analgesia and sedative properties, which is analgesic sedation, right? So what else on ketamine? So that's the idea behind utilizing it, but we have to make sure that our docs and our providers know that the dose that's there by default is not exactly therapeutic, right? It's not where it should be. It needs to be adjusted.